Good evening, everyone, and welcome back to PATHOBIOLOGY. Today's evening, we are going to study a very important topic, that is Gold 2023. What are the newer changes that has been made from previous year, Gold 2022? This year, what are the new changes that you are going to study? There are 14 golden points, okay, which are very, very important. Okay, we are going to study one by one without wasting much time. Coming first to the definition, a very important change in the definition of COPD. Now they have defined COPD as a heterogeneous lung condition characterized by chronic respiratory symptoms like dyspnea, cough, sputum production, exacerbation due to abnormalities of the airway, which could be either bronchitis or bronchiolitis, and or alveoli, which could be emphysema, that cause persistent, often progressive airflow obstruction. A very important change, okay, from the previous goal 2022. After definition, they have introduced a term called PRISM, PRISM, which is a preserved ratio impaired spirometry. Okay, what is meaning of preserved ratio? Here, the post bronchodilation FEV1 by FVC is more than 0.7, means which is not fulfilling the criteria for COPD, but there is impaired spirometry, means the FEV1 is low. Okay, this is seen mainly in the pre-COPD patients. I have discussed in the previous video what is pre-COPD. PRISM is mainly seen in pre-COPD patients which are at higher risk of progressing to COPD. Third, the trajectory curve which they are given, it is the FEV1 over the life course. They have made it into the four categories: TR1, TR2, TR3, subset 1 and subset 2. Okay, TR1 is the normal lung, normal without any risk factor for COPD. You can see that it reaches the FEV1 reaches the maximum at around 10 between 10 to 20 years of age, and then it gradually starts falling. And then you can see TR2, here the small lungs, but there is no COPD. TR3 is normal initial FEV1 but with rapid decline because of COPD. It could be because of smoking or any other reasons or genetic factors, any other things. TR3, the purple one, is because of small lungs leading to COPD. Okay, which shows the important thing that even the small lungs can lead to COPD. This is the third thing, there is the trajectory curve. Fourth is GETomics, that is causative factors, the interaction between the genomic, environment, and time duration. So what is as we studied previously in previous goal 2022 also they had mentioned regarding the genetics, but in this goal 2023 they have very much focused on the genetics, because there is it is the now what they have said is COPD is an interaction between the genetics, environment, and the time. Genetics like mainly the alpha 1 antitrypsin deficiency, serpegina 11 and 9 gene mutations, environment like smoking, exposure to noxious particles, air pollution, time duration means like duration of which the patient is exposed. Okay, this all in combination causes your COPD, that is known as GETomics. Okay. I mean, the fifth major change, that is pathobiology. They have introduced this in gold 22, that is pathobiology. It is mainly the inflammation, because the balance inflammation, there is balance between the inflammation and anti-inflammatory things. Structural changes because of the COPD, which could be because of the small airway damage or perilobular bronchial fibrosis. The vascular changes, a small amount of COPD patient can have vascular changes like which can lead to pulmonary hypertension. A very important thing, etiotypes of COPD, a very important things which they have introduced in gold 2023, that is etiotypes, also known as taxonomy, proposed taxonomy for COPD. It is mainly based on the etiology. This was done to avoid the negligence of other causative agents other than smoking. What previously we should think the COPD is mainly because of smoking, but other factors were left behind, other causative agents were left behind. So this was done mainly to focus on the other etiotypes. Classification COPDG, that is genetically determined because of alpha antitrypsin deficiency or anything. In the previous slides we had seen the genetics GETomics. Okay, COPD due to abnormal lung development, small lung, environmental COPD, COPDC, or that is because of smoking. COPDP is because of biomass and pollution exposure. COPD due to infection, COPDI, COPD and asthma COPD overlap, that is COPDA. COPD of unknown cause, that is COPDU. Whenever you don't know the cause of the COPD, you can label it as COPDU. This is mainly based on the etiology. This is on the etotypes of COPD. A very important slide. Coming to the next one, ABE assessment. If you have seen my previous video, we had discussed regarding the ABCD tool assessment. Now it is ABE. There is no C and D, it is E. Okay. The gradings are remaining the same. There is exacerbation history and the MMRC and the CAT scoring, and A, B, and E. Why E? Because it is mainly to focus on the exacerbation. It is mainly to focus on exacerbation. So they have made it as A, B, and E. Okay, very important change. A, B, E. Previously we studied A, B, C, D. Now it's A, B, and E. Okay. Coming to the use of CT in the stable COPD, what are the uses of COPD in the stable COPD patient? Why we need to get a COPD, CT in HSCT thorax in a stable COPD? For differential diagnosis, for bronchiectasis or other typical infection, lung volume reduction surgeries like endobronchial wall therapy, or you are planning for LVRS, lung volume reduction surgery, there CT is needed. One and mainly important thing is lung screening, because COPD patients are more prone for malignancy because they are because of the causative factors like smoking. So because of the three things we used HSCT thorax in COPD patients. And one important thing, what is the bronchoscopic interventions that they are doing in COPD patients? First we can see symptoms: chronic mucus production, exacerbation, dyspnea. What are the disorders and what are the surgical and bronchoscopy interventions they are planning? For chronic mucus production, that is chronic bronchitis, they are planning nitrogen cryospray and rheoplasty, that is radiofrequency ablation. And exacerbations, like for acute chronic bronchitis, bullae, emphysema, bronchomalacia, they are planning targeted denervation. For dyspnea, there is a do a bullectomy, large airway stenting, endobronchial wall, coil therapy, laser ablation, lung sealants, lung volume reduction surgery, lung transplantation. So these are the things which they do if the patient has persistent dyspnea. Okay. See, COPD patient will have all these three symptoms in combination, but which is the more prominent symptom? Based on this, the surgical interventions are divided. Initial pharmacological management, we have previously studied for A, B, C, and D. Now it's A, D, and E, as we studied in the previous slide. For A, it is any bronchodilator. For B, LABA plus LAMA. For C, E, LABA plus LAMA. You can use LAMA, LAMA plus ICS if the eosinophil count is more than 300 or there is a repeated history of exacerbations. Okay. Contraindications will be again mycobacterial infections or repeated pneumonia and the eosinophil count less than 100. Definition of COPD with acute exacerbation, we label it as ECOPD. Previously for acute exacerbation, we should write as COPD with AE. Okay, now the term which we use or the symbol which we use for acute exacerbation COPD is ECOPD. Okay, defined as an event characterized by increased dyspnea and or cough with sputum that worsens within the 14 days, which may be accompanied by tachypnea and or tachycardia, and is often associated with local increase in local and systemic inflammation caused by infection, pollution, or other insult to the airways. A very important definition is COPD, exacerbation of COPD, increased symptoms within the 14 days associated with tachycardia, tachypnea because of the increase in the local or systemic inflammation because of the exposure to the infection or pollution or because of the any other insult to the airways. ECOPD. Lung cancer in COPD. What are the risk factors for development of COPD in development of lung cancer in COPD patient? Age, important, more than 55 years of age, smoking history, more than 30 pack years, presence of emphysema by CT scan, presence of airflow limitation, FEVM by FEC less than 0.7, post bronchodilation, BMI less than 25 kg per meter square, family history of lung cancer. Okay, risk factors for development of lung cancer in COPD. Periodontitis and COPD, a important comorbidity. It is in the COPD and comorbidities chapter. What they say is increased periodontitis increases the risk for acute exacerbation of COPD, and if the periodontitis is treated, there is a lesser risk of acute exacerbation of COPD. They have gone through various number of articles, and they have proposed that periodontitis and COPD. Okay. Coming to the 14th and the last important point, they have made a COPD follow-up checklist. Whenever the patient because of COPD comes for a follow-up, we need to ask all these 7 points. That is baseline symptoms, there is an increase or decrease, COVID-19, written action plan, recent admission and emergency visits, COPD self-management, main issues, and summary. Okay, these are the main 14 golden points of Gold 2023. Okay, thank you all for your patience listening. Thank you.